So for the next half hour or so, we're going to talk about some of the challenges that we have in neonatal ventilation. And I'm not going to talk so much about the actual ventilator settings in this, but talk about how everything that we do in the care of the respiratory care of the neonatal patient doesn't just treat their pulmonary disease, but also has consequences on the neurodevelopment. Brian had mentioned before that we need to start thinking about this concept of neurorespiratory care. And that's more of what this talk has to do, because we all want to be able to answer those questions better. Will my baby be normal? Which we really can't answer right now, because we only know that either you're not going to die or get BPD by a certain percentage, but not a lot of these studies really tell us what's going to go on neurodevelopmentally. The same conflicts of interest that I've had, more importantly for this lecture, since we'll be talking about flow sensors and some ventilator concerns, is my relationship with Drager, which is for research studies not related to ventilation. So just for an overview, we're going to look at what the literature tells us about all the different things that we do, and some of the challenges with implementing some of these recommendations that we have and the consequences. And when I say recommendations, these are really soft recommendations, because there really isn't a whole lot of evidence out there. As with many of the questions and comments from all of these talks are, we don't have a randomized controlled trial for that, but we're giving you recommendations that come from a consensus report or from a retrospective trial. So the evidence that we have for treatment of these very sick babies really isn't all that great. So they're still kind of soft recommendations. And unfortunately, I end up coming up with more questions and answers at the end of this talk. But we're going to talk about airway leaks and how they are sometimes a real challenge. And then tidal volume accuracy and flow sensors, which we've talked a lot about how good volume ventilation is, but there's a lot of challenges with implementing that. So we're going to talk about that as well. So looking at our long-term effects of invasive ventilation, starting off with our evidence, and really hyperventilation and hypocarbia is one of the main contributing factors to our cystic brain lesions and periventricular lipomalacia, and this is something that we really need to watch out. We say the swings in CO2 are bad, and this is what it causes, and it definitely causes major consequences long-term on the brain. And when we're talking about our CO2 ranges, is we really don't want to see them fall below 30. If they're going to swing below 30 even for a small period of time is very, very harmful, especially within the first week of life. Hypercapnia increases the risk of intraventricular hemorrhages going in the other direction, and then ventilation with low PIP and low peak levels can also lead to atelectic trauma and volume-induced lung injury, and we'll talk about that as we go forward as well. Also contributes to bronchopulmonary lipomalacia with all of the lung injury that occurs not only with ventilator settings for ventilation, but also for oxygenation, as we know that the oxygen itself is injurious to the lung tissue. So there was a study done by Cohen and colleagues that was in pediatric research in 2001 that looked at mechanical ventilation increases in both cerebral pressure and fluctuations in cerebral and venous blood flow velocities, and really how these changes that we go for our swings in oxygenation and ventilation causes the same velocity changes in the brain. And that's what causes all of these problems. There hasn't been much studied since this one coming out, and I'd like to see a lot more research on that, so it was a relatively small study. We also have elevated levels of inflammatory kinases that are found with lung injury, and we also believe that this also causes damage to the white matter of the brain, and this was proven in a 2008 study in clinics of perinatology. We also know that routine suctioning and repositioning of the endotracheal tube changes the cerebral hemodynamics and oxygenation. And there are two papers that gave us this information, one in Pediatrics in 2008 and an older one in Journal of Pediatrics in 1992. So every single time we disconnect the vent circuit to turn the baby, if that's a common practice in your ICU, whenever we suction routinely just because we're already in there doing something, even though there isn't actual evidence of having secretions in the airway, those small little acts of care that we see as preventative also are causing harm. I know for us, for we've been able to really reduce the disconnections of the ventilator settings greatly by having a second person in there every time we're turning and repositioning our babies. But we still have some of our nurses that are very resistant to having a second person in there to turn somebody that's a kilo. They think they're so small, I can do this on my own, but it has nothing to do with their ability to turn. It has to do with doing it smooth enough, making sure nothing is disconnected, because that even couple seconds of disconnection can have some pretty significant consequences. Looking at open versus closed suction, predominantly in the U.S. now we use closed suctioning in our inline suction catheters, and that came about mostly for limiting disconnections, limiting the amount of suction catheters that you're using, as well as for prevention of ventilator-associated pneumonia and causing contamination within the ventilator circuit. We have two studies that really take a look at these. The one by Curley and colleagues showed that closed suction minimized lung volume losses, which you can imagine, all that PEEP and mean airway pressure that we're still trying to keep in there and maintain completely goes away immediately when you disconnect. There's a slower recovery of end expiratory lung volumes, as well as recommended recruitment maneuvers after suctioning. So every time you do suction, even if it's with closed, they're recommending you do some sort of recruitment maneuver to get the lungs back to where they should be to increase your mean airway, get your mean airway pressure and your vital capacity back to where it should be. Our second study, in that study by Curley and colleagues, was a randomized crossover trial of 20 infants after cardiac surgery. When they did a crossover, each infant got both closed and open suction, and they were actually looking at end expiratory lung volumes measured at baseline and then after suctioning with EIT. The next study by Jorgensen and colleagues was actually in 2012 in the journal Critical Care Medicine, and they looked at it was a prospective observational trial with crossover of 50 suction procedures was selected at random that they looked at, and then the documentation of the measures, and compared baseline 3 minutes and 5 minutes post-procedure, as well as in between the two types of procedures. And they compared the changes in heart rate, oxygen saturation, mean airway pressure, and both different suction methods. And they saw no difference between using open or closed. At 5 minutes, they had all returned to baseline, but they did see an increase in heart rate and a lower oxygen saturation with the open suction versus closed suction. Tingey and colleagues did this study was published in Intensive Care Medicine in 2010, and this was an animal study where they looked at open versus closed suction with two different suction catheter sizes, and these were 2 equal piglets, and there were 6 total for this trial. They had a 4.0 ET tube, and they used a 5 French suction catheter and an 8 French suction catheter, both open and closed. And they saw a decrease in the end expiratory lung volume and a decrease in tidal volume with all suctions. But with the closed suction, they thought that it was protective against de-recruitment. And this is something that we kind of think of course we know that. But they also saw that the smaller suction size catheter that was used also saw a reduction. And this makes sense to us in that the 8 French is pulling more. Every time you're suctioning, you're not just getting secretions out of the airway. You're taking away the mean airway pressure with the oxygen and the CO2 and the nitrogen and everything else that's in there. So if you use a smaller size catheter, you're going to get less secretions out, and you might need to make more passes. So is it more harmful to use a smaller suction catheter if you just have to suction more? So that's a study that really needs to be done on infants and really looking at how many actual passes of suctioning do you have to take each instance of suctioning, and is it really beneficial if you're actually having to suction more with that smaller size. Taking a look at neurodevelopmental disorder risks with mechanical ventilation, the study was in 2014 in the research of developmental disabilities. And it had a 10-year retrospective review of follow-up info on extremely low birth weight infants between 1998 and 2001. So it was a very large retrospective trial. They were on mechanical ventilation for greater than or equal to 15 days. Then saw an increased risk of CP and ADHD even without any significant neonatal brain damage. So even if you don't have any brain bleeds, you still can end up with CP and ADHD. They did, however, see no correlation to the autism spectrum disorders or any intellectual disability, so there wasn't a reduced IQ number at all, but they did see an increased risk in CP and ADHD. So they recommended developing brain protective respiratory support strategies. And reading this study was when I first started to think about that. Brain protective respiratory support strategies. And that's not something that we learned in respiratory school. I'm not sure if that's something that you're teaching here in medical school, but as Brian said, we have a hard time when we're thinking about lung diseases and ventilation to get outside of the lung and think outside at the rest of the body, and particularly to the brain. Mostly in response to some real-time hemodynamic and oxygenation changes. And unfortunately, the velocity changes in the brain and some of the other things that we had mentioned in some of the earlier studies, we can't see that real time. That's not on the monitor. It's not a vital sign that we look at, but maybe we should be. So looking at with all the things that occur with mechanical ventilation, we say non-invasive support when able. Of course, I gave myself away with most of my other talks today, in my opinion, that isn't always the best thing. But we need to know when to say enough is enough. But the support trial talked about, this was the study to understand prognosis, preferences of outcomes and risk in treatment in infants, and it said that 35% of 24 to 28 weekers randomized to CPAP arm required intubation in the delivery room. So of all those that they randomized to just get CPAP, still 35% of them needed to get intubated. So we really have to remember, we need to know when those cutoffs are and when enough is enough. And 83% of those that required intubation, of that 35%, at some point in time during the trial. So even though they were random, even the ones that made it past that, out of the delivery room on their CPAP, still 83% of them required intubation at some point in time. So even starting in a delivery room with CPAP or non-invasive doesn't guarantee you're not going to get intubated. And we need to continue to make those assessments. And our major causes of intubation was poor gas exchange, increased work of breathing, apnea, and need for surfactant. And these first three, we know, greatly cause brain injury, as we've talked about in several of the other talks. In a couple of the studies already here, we know that all three of those are going to cause the velocity changes in the brain, they're going to cause the bleeds. So we really want to make sure that we're picking up on it as soon as possible. And we really need to make sure that we avoid hypo and hypercarbia, because the big swings, again, are the problem. So how can we ventilate in each settings that we choose and how they're very different? And there's a lot of things that we can do by choosing mode, peak levels, and eye times. These are the three, to me, that are the main that we really need to kind of keep in mind. So when using assist control versus control versus assist ventilation, on your control mode, you lead to more stable oxygenation and ventilation. First, your assist modes are going to allow your patient to trigger and control the own dynamics of their breath. Each one causes better work of breathing, better synchrony. The other one causes more stability. We need to find a way to really combine those together. The advantages of your assist modes are really lower and more consistent airway pressures. Those are really with our hybrid modes. As we talk about, they can give you that constant volume while still providing the lowest pressure possible, letting your patient breathe spontaneously. And when you have more smooth ventilation pattern, you're going to have less intracranial pressure swings and less problems on the brain. When you have increased patient comfort, you're going to have less sedation, and you're going to have quicker extubation times, getting off the ventilator quicker. And also greater synchrony, causing less air trapping, less airway leak. But really with all of these and comparing the two modes, there's no difference in mortality that we've seen in any of the studies, and there's definitely been no assessment of morbidity and long-term outcomes over time and use of them, even though mortality. Like I said, most of our research now stops at mortality or PPD, and we're not looking at any of those other pieces. To synchronize or not, this is one of the other questions. The advantages of synchronized assist modes are really larger and more consistent tidal volumes, greater oxygenation ventilation, using lower work of breathing, lower respiratory rates, but there's no difference in mortality. So when we only look at mortality as our outcome, it doesn't really matter if you synchronize, but when you look at everything else that could potentially cause problems neurodevelopmentally, you should synchronize because it causes a more consistent, smoother ventilator pattern. Using pressure versus volume, in this study that came out in 1994, it was a randomized controlled trial, old study, but very good trial, using volume versus pressure, and they targeted 5 to 8 mLs per kilo as the initial strategy in preterm infants with RDS. And they showed that the volume control group had a shorter ventilation time. The key with this is really setting your volumes and making sure that your volumes are adequate. The volume control, those in volume control mode trended towards a lower BPD rate, and that was statistically significant. There's a 2010 Cochrane review, which looked at 12 randomized controlled trials comparing volume targeted ventilation to pressure control. And they saw that volume targeted ventilation reduced outcomes of death or CLD, pneumothoraces, hypocarbia, PVL, or grade 3 or 4 IVH. And these are all a number needed to treat, which was very helpful for a lot of people. It's a statistic that we don't use very often, but your ideal number needed to treat is 1. Every infant that you treat with it gets this benefit. There are often times, with many different therapies, we don't know what the number needed to treat is, or it's in the thousands to get the benefit of 1 patient. So these are relatively low number needed to treat to get benefits. And also, there are various, in this study, various volume-targeted modes were used. Therefore, it's really hard to make a consideration as to which one was superior. When we're looking at PEEP settings, there were several animal studies that suggested a reduced tidal volume, and you were able to reduce your tidal volume while using accurate PEEP. And this can really reduce lung injury. As we know, volume is what really causes that stretch injury in the targeting. So if you're not trying to push past that airway obstruction, if you use adequate PEEP to open up, you're going to get less pressures and less volume. And these are the 3 animal studies that showed that. They're relatively older studies, and we know there are more coming, but it's something that we've already proven. So to keep going on that. As you saw in a couple of the case presentations, we have infants that are brought to us because of the great hyperinflation. They're on 3 of PEEP, and we up it to 12 or 14. And that's when we're able to really see the hyperinflation go down. So PEEP really matters. But it's scary when you have a 2-kilo patient and you're on a PEEP of 12. That's not really done much in the neonatal ICU, but in our unit, that's mostly severe chronic lung disease. Our NICU is 99 beds. It's very large. Most of them have been at another hospital and had problems before they came to us. So we have a lot of challenges with them. But our average PEEP on our chronic lung disease team, which is around 40 babies, is 16. And we've sent babies. We had one kid who was really happy on his 24 PEEP, but we couldn't get him on a home care ventilator to send him home because no home care ventilators in the U.S. go to 24 PEEP. So we had to find some challenges and bring them down. And then, no home care company wants to take them home on 22 a PEEP or 20 a PEEP because that's scary on a baby, scary on an adult. But unfortunately, that's where we found our happiness. Using recruitment maneuvers in the NICU mostly occurs when we're on high-frequency ventilation, not necessarily on conventional mechanical ventilation, but the evidence suggests that it could be very helpful in helping to determine your optimal PEEP, as well as reducing lung injury. And there are 2 studies that aren't extraordinarily new, one in 1999 and one in 2003, where if we did more recruitment maneuvers more often, it might help us determine what that optimal PEEP level is. Get there sooner instead of continuing over the course of days to increase the PEEP. If we can get to that point sooner, we can reduce some lung injury by getting the lungs open. Inspiratory time, my favorite setting. This really can help you improve the synchrony and by making sure that you're setting it appropriately. Too short or too long, as I've said multiple times, can cause asynchrony. And really knowing how your ventilator functions and sets the inspiratory time and how it affects all the modes. As we said, each ventilator company creates their own algorithms. None of them can use the same ones because they're all copywritten. So knowing how your machine works and knowing how to use it well is just as important. There was a 2004 Cochrane review that looked at a meta-analysis on the effects of inspiratory time on air leak, BPD, and mortality. And what they saw that an I time that was long, which was greater than 0.5 seconds, was associated with increased rates of air leak, mortality, and mortality before discharge. But they showed no difference in the rates of BPD. But what we feel contributes to this is you have a lot of intrinsic PEEP that continues to build up. That causes a dysynchrony because you can't trigger the ventilator through all that intrinsic PEEP. And that's what causes your air leak and your BPD and can contribute to mortality. The study also included in the review poor treatments with antenatal steroids, surfactant administration, and newer ventilation modes. I'm sorry, these studies were all done prior to our use of antenatal steroids, surfactant, and newer ventilation strategies. So this is really a study that needs to be done again because it's kind of not applicable anymore, at least the studies and then the review of the studies. So although it looks like it could be good and it could be a good reason to say set your eye times appropriately, when we look back at the study, so much has changed, they're no longer valid. And this was the slide I'd shown prior on our setting of our accurate PEEP, and one of the conversations I had afterwards is you all look more so at your flow loops than your pressure loops. That was interesting and good for me to know, and I usually show these together and teach with them together, but I have found that a lot of people with the way that these sinus water waveform is, it gets people confused, and there's so much other artifact that can occur down here that confuses people, and which is why I've tended to get all of our fellows when I'm teaching them ventilation to remember more of the pressure waveform. You can use either one, whichever one works best for you, as we all learn differently and remember things differently. But the most important point is assessing it and changing it often, because it oftentimes needs to be changed frequently, similar to your tidal volume and everything else, as your patient condition changes. So going into some of the challenges that we know we found with all the options that we have today with our ventilators, we forget about the basics. When we take our advanced life support classes, or our adult advanced life support, pediatric advanced life support, one of the things that we always concentrate on in those classes when we're teaching is basic CPR. If you don't do basic CPR well, you can't do advanced CPR well. And it's the same thing with ventilation. If you don't do basic ventilation well, it's really hard to do advanced ventilation and understanding everything that you do. So we really want to take a look at all the stuff that causes challenges. And you need to work on those. You can't just ignore the challenges, but we have to work on them. Our proximal flow sensors. We have large airway leaks. We have way too many options. There are so many types of ventilators, and so many types of modes, and so many different ways to use them all, that sometimes we get lost in knowing how to use each one of them really well, because we want to do everything. When to admit defeat. I think this is the hardest for every single one of us. When to know that what you've been working on really, really hard for a long time is not working. And we always want to say, I can make it work. I can keep this kid on non-invasive therapy, and it's going to work, and they're going to be fine. But are we causing more injury than not? And that's the problem. So if you're not growing, then you're not ventilating well. And that's what we say all the time in our unit, but we're not growing. So we have to be doing something different. So ventilator recognition and the ability to synchronize or not with each patient, knowing how your ventilator works, is very important. Using proximal flow sensors, and how does that flow sensor work? We have a lot of different ventilators that have proximal flow sensors, but they all have different characteristics and different algorithms for use, and knowing how they use is very important. Some of them have a lot of extra weight. There's mechanical dead space. Some of the alarms and the additional things that happen with disconnections, we need to really make sure we're looking at them. Not all flow sensors are created equal, and each machine does something differently. Rob DeBlasi, who you all had come speak with you a few years ago, has done a great side-by-side comparison of all the different types of ventilators currently on the market in the US and which flow sensors do what. The Draper ventilator has sensing and triggering at the flow sensor right here at the airway. A lot of people think that that is the ultimate, and that's the best thing to have. Some of the other flow sensors will measure, but they don't trigger. Trigger still happens at the ventilator, which we've already heard Brian say he much prefers. Some other people prefer it being at the airway. So it really is knowing what your ventilator is doing. And if your trigger and your sensing is mostly happening at the ventilator, do we need this extra proximal airway sensor if all the other measurements are accurate? Get rid of the weight. Get rid of all the extra dead space. So it's really knowing how the machines work. Large airway leaks. This is a huge challenge. This is one of the things I struggle with the most. We use a lot of uncuffed ET tubes in the NICUs. That's been our standard forever. In fact, using a cuffed endotracheal tube has been, like, don't even go there, don't even mention it, don't even bring those cuffed endotracheal tubes into the NICU. We started using them more and more in our NICU. We do have an unconventional population, so we need that. But we've even sometimes, we've put the cuffed ET tubes in, and we've tolerated a certain amount of leak. And the fact that you don't have to re-intubate just to upsize the tube, and you can just increase the amount you have in the cup a little bit more, makes it easier. And it's less risk on the patient because you're not adding that extra extubation reintubation procedure that we know can cause some additional harm. So with larger airway leaks, we have the problem with inaccurate tidal volumes, and our inability to volume ventilate. You're unable to maintain your FRC, your PEEP, you tend to get auto-triggering, and you have the reduced ability to trigger at all. There are some ventilators that have leak compensation. What this does is it adds that extra flow to the circuit to help maintain PEEP or to get your pressures. But this flow then can cause more problems as well, and it is harder to breathe against. So how much leak is too much, and when do you need to do something about it? We hate having to upsize endotracheal tubes. When you do have patients with very significant lung disease and poor lung compliance, upsizing the ET tube or putting in a cuffed trach just really means you're dilating the trachea a lot of times. Because that pressure that's in the airways, lungs, is going to push up somehow. It's just going to make the trachea bigger. And that in itself isn't a problem, or is a problem. So usually any leak greater than 30% is what we kind of target clinically. When you know that some of the measures that you're getting on the ventilator you can still trigger are still relatively accurate, you can still do volume ventilation. Anything greater for 10% for research purposes is bad because the air range within your numbers is really too much. So some other challenges. Again, remembering the basics of ventilation and lung injury and what really causes that lung injury. Using enough PEEP to really combat all of that injury, because we don't want to really over-distend. Utilizing your graphics to really assist you is very beneficial. And using all of them, your flow volume loops, as well as your different curves. This is during normal conventional mechanical ventilation, the swings that we have that go between our injury zones. And our injury zones are too high and too low. And mechanical ventilation does this. And every time we breathe in and out, we go above and below those injury zones. And we want to stay out of that as much as possible. Using accurate PEEP, you can at least get up here and avoid the lower injury zone. But you really want to be ventilating in that area, in that section. So this is another, really looking at your lower inflection points and your higher inflection points when applying an accurate amount of PEEP and really getting that critical opening pressure. And you can see how just adding some extra PEEP really changes using your waveforms. And over the next couple days, we'll go to waveforms a little bit more. So our next challenge is really, what do we trach? And this question we kind of already covered. So I think I have a study in here that I talked about, though. They sought to determine the risk of death or tracheostomy in infants with severe BPD at a referral from referral to regional NICU. And this was really one of the major challenges that we see and know when to do. As our primary outcome was death or tracheostomy before discharge. And what they saw, and this was a retrospective cohort study of infants with severe BPD that were less than 32 weeks between 2010 and 2011, so the data is relatively recent. And this, again, was in the NICHD database. And of these severe BPD patients, they defined that as infants who needed an FiO2 of greater than or equal to 30% oxygen, or they needed greater than 2 liters of a cannula, or on positive pressure ventilation. So nasal cannula and positive pressure ventilation were at the same level of severity. And this study here is the study down there. It was in Journal of Perinatalology in 2014. And what they saw was that in the results that all associated with the risk of death or tracheostomy was a lower gestational age of birth, a later age of referral to pulmonary management, so the sooner the better, to get into pulmonary management or to a center that really knows how to ventilate and treat these children. Mechanical ventilation at time of referral, and having a clinical diagnosis of pulmonary hypertension. Having pulmonary hypertension was huge at needing a death or tracheostomy. And then systemic corticosteroids after referral. So once they were at the referral center or into pulmonary care, if they needed steroids again, that increased the risk of death or getting a tracheostomy. And also the occurrence of bloodstream infections after referral. So the later that you're getting these infections, the worse off they tend to be. So just to recap quickly, and hopefully I helped keep us back on track of time, you really want to have more consistent tidal volumes, 4 to 5 cc's per kilo. There was a study that Dr. Kessler did where they really looked at the different types, different levels of volume ventilation. 5 mLs per kilo or 5 cc's per kilo was really kind of that target where you want it to be. Not too much lower, not too much higher, at least for your preterm infants. Really needing to set the appropriate eye time and resetting it over time. It should not be a set and forget setting on the ventilator. Same thing with your PEEP, appropriate levels of PEEP, and don't be afraid of it, which is kind of hard, I know. But don't be afraid. Give as much as you need to and then back off when you don't need it anymore. Permissive hypercapnia, as long as it's not too high and you're not getting big swings. And really that brain supportive respiratory strategies is really what we're looking for. 2 people when you're turning, making sure the turning with nursing care is consistent. We're not suctioning too much or too long, only when needed. And you can see that on your airway, on your waveforms, on your ventilator, when suctioning needs to happen. So it might not be just when you're in there changing the diaper that let's suction because we're in here. That's not the best practice, even though that's our common practice for nursing. And minimizing disconnections when at all possible. Those things we know. Keeping the course of ventilation and oxygenation as smooth and consistent as possible and not having large swings is more of what our brain supportive respiratory strategies are. And unfortunately, I'm sure for you all, but for me, every time I do this talk, I get more questions than I get answers to. So how do you really determine that best PEEP level? We don't know yet. So you can look at your waveforms and you can kind of guess a little bit, but we don't really know. We're currently in the process of doing a study measuring intrinsic PEEP with esophageal pressure monitoring to help us understand that. And we're actually doing videos of the waveform graphics and the assessment of the infant after our PEEP changes with intrinsic PEEP. And the efforts that for those centers that aren't research centers that don't have esophageal pressure monitoring for infants available to them, we can say these are the key pieces in your respiratory assessment, and this is where you're going to see changes on your ventilator waveform graphics that can show you when you hit that appropriate level of PEEP in an infant. Because on most of our ventilators, we can't just do an expiratory hold like you can in adults. Then how much air leak is really acceptable? We say approximately 30%. We don't really know that that's true. That's a guesstimate. But we need to do a study on that to find out when that leak is causing more harm than good and when we're not really getting the ventilation that we think we are. And then when is the best time to intubate? When we've been on non-invasive for how long? To us right now, we're not growing and we're not able to tolerate handling. But maybe you're just cranky that day. How long do we wait? 2 days, 3 days, a week, 2 weeks? We don't really know what that week time frame is to just say, let's hold on and let them grow and stabilize out. And that's something that we really need to help to try and figure out for us. And then more specifically, what are brain supportive respiratory strategies? It's going to be more of a total care, and it's everyone that touches that infant and the things that they do. And we need to get a better bundle of care for these respiratory brain supportive strategies that we can really do. And in all of our future ventilation studies, really look at not just at the BPD as our outcome. We really need to be looking at our neurodevelopmental outcomes as well. And unfortunately for that, we need a better measure because waiting until they're 2 years of age to get a baby 2 it's too long. We need to be able to assess them before they leave the hospital or at different time frames. And how big of a role should nutrition play? It's a dance right now. It's a witch's brew for people trying to figure out what is the best amount of protein and calories and what other vitamins and minerals that we're putting into their feeds because we really don't know, and we need better ways to assess that and better ways of determining what really should be in our formula and our nutrition to really make sure that we're doing the best thing for them. And then, as I said, all future research, we really need to be looking beyond our short-term ventilation outcomes because chances are there isn't much that's going to affect mortality anymore because we've gotten to a really good point. We really need to be looking at all the morbidities to make sure that everything that we do might not change mortality. You still might get severe BPD, but maybe it can affect some of our other longer-term outcomes, and it would really be worth that practice. Thank you all.
Thank you very much, Professor Natalie Napolitano, for her excellent and beneficial talk.